Our first speaker, I'm very excited to introduce you. His name is Ekkehard Kasper, and I just met him for the first time this morning in person. We've definitely talked, but I'm thrilled to have him here. He shared with me his slides, and he's going to give a comprehensive examination of the surgical management of Chiari. And just a little warning, I saw the slides. Some of them are a little bit gruesome, so yeah, be ready for that. Welcome.
Let's hope for the best. Which device do I press? This one is for advance. So first of all, thank you all participants for coming. Thank you for the organizing committee to give me an opportunity to participate in this and give a talk on surgical management of Chiari. And I'm a local neurosurgeon, sort of raised here in Boston and embedded in a number of different institutions. I have nothing to declare other than the institutions I work in. And if anybody is interested in the slides later, they will be shared. You don't need to write it down or take photos. I was lucky that I was given a little extra time to give you a general overview to the topic, because I think it leads nicely into the day. So we will spend a little bit of time on the general introduction of the disease, the definitions, the workup, and the epidemiology. And then I want to focus in the second half on the surgical approaches that most of us clinicians use. And I give you one good overview of best clinical evidence, why things work and why other things may not work so well. And at the end, I tell you why I do it the way I do it. So a Chiari malformation is identified when parts of the cerebellum are located ectopic, meaning they are pushed downward into a direction where they shouldn't be. The foramen magnum is the big hole connecting the cranial cavity to the spine. And that's the only exit site for the brain as such. So when the P fossa is small, the back of their skull is underdeveloped, the tissue is pressed downwards, and you basically push a cork into a bottleneck, and thereby you take away the space for the fluid that needs to get outside the head into the spine, and therefore you get impaired CSF flow. That's really the underlying problem we are trying to fix. Systolic pressure then may contribute to make this much worse by constantly pounding on that junction, and you get shear injury to the junction of the parenchyma, forming cavities called the syrinx, and the syrinx then creates a lot of more of the surgical morbidity and the neurological dysfunction. Let me stand on the other side, it's easier. The diagnosis is really in the literature all over the place, but most of us agree that radiographically displaced by more than 5 centimeters when the tonsils are pointing down between the line that creates the foramen magnum. You speak about a radiographic Chiari malformation. There are no real routine biomarkers that you would pick up on a routine examination that will predict you have one or not. But Chris Carley is going to publish on this more extensively and tell you more about it. There are more experimental studies where you can actually pick this up. Therefore, examination and neuroimaging is the prime importance. MRI is the treatment to diagnose. And these are the 3 elements. We usually start with the T1 parenchymal image, so that shows you how the brain substance is built. You want to see the downward pushing of the tonsils into the space. You also see that the tonsils are not perfectly located in the midline. They are coming in from the side, pinching the lateral fibers of the cranial cervical junction first. Then you go over to T2 images that show you the fluids. And you want to see that the fluid spaces that are normally visible around the spinal cord anteriorly are occupied by tissue, taking away the cross-sectional area available for fluid. And later on, you can see that within the spinal cord, you see cavitations that are responsible for a lot of the symptoms. Now, this is different from the clinical Chiari syndrome. So there are patients that present with all the signs and symptoms, but no clinically identified, no radiographically identified disease. So separate the 2 of them. The manifestation is usually pain, mostly in the neck, occipital headaches, rarely with nausea and vomiting, often with paresthesias. They start at the side, upper extremities, and neck. Then myelopathy if the spinal cord gets compressed badly, and cerebellar dysfunction, which can change your gait. If there is formation of a syrinx, a cavity, you get additional neurological deficits. We often see that in patients that have scoliosis. There can be brainstem compression with cranial neuropathies. For example, the lower cranial nerves get stretched, you have swallowing difficulties, you have difficulties with the change of your voice. You may have tinnitus, and some patients have hydrocephalus and elevated ICPs. We all clinicians ask these patients, is this ongoing? Is this fluctuating? So many patients present with classic Valsalva-induced aggravation of symptom. That means if you cough, sneeze, bear down, you have more symptoms than in the supine position in bed at rest. However, many patients are asymptomatic. Most of us clinicians have some form of standardized assessment. I use questionnaires. We use the standard ones, SF36, disability scores. We use Chiari outcome studies from Chicago. I've made sort of an office questionnaire not to miss any symptoms. Every patient gets that before, after, and at every single visit they come thereafter for the next 2 years. So you can actually see the gradual improvement over time per domain. And if we could all agree in academia to use the same questionnaires, life would be a lot easier. So synopsis, the history and clinical assessment is really key, giving you an idea where you want to go. Direct CSF flow studies come next. We will hear about CNF flow studies where you want to see the normal spinal fluid pulsations give you a signal across the craniocervical junction. And especially at the level of the foramen magnum, you want to see anterior flow and, if possible, posterior flow. And in Chiari patients, you see a dropout of the signal at this level. Sometimes you don't see any signal posterior to the cerebellum. So that defines the disease quite well. I also get pre-surgical CTA and CTV because I want to understand the vascularity across the junction. Makes a difference in the way I decompress and how I approach this problem. The disease has been around for 125 plus years, actually 135, and we still haven't figured out how to fix it best, right? They came up with multiple versions of Chiari. The first two ones are the classic ones. Chiari I usually has one problem, the tonsil descent. Chiari II has a second problem, which is usually some form of spina bifida, tethered cord, or secondary lesion in the spine. Chiari III means there's an opening at the back of the skull and the brain is herniating out. That's a really difficult problem to fix. Chiari IV is not really a Chiari, it's an underdevelopment of the cerebellum where the P fossa is empty, therefore you don't have flow obstruction, but it's classified in the same disease group. So let's go briefly through number 1 and 2, just to give you an idea how I fix this. The cerebellar tonsils protrude below the foramen magnum without necessarily causing other trouble. You see that the tonsils here are pinching down. So I usually say Chiari I has one problem, it's just at the craniocervical junction, right? It is defined as more than 5 millimeters, the foramen magnum is the culprit, and there is plus minus a syrinx that you can see later in the cervical spine that is responsible. Hydrocephalus prevalence in my patient population, 10%. I wouldn't say not more than 10% of patients show up with hydrocephalus pre-op. They can have different pathogenesis. We differentiate between congenital and primary, inborn, de novo, which is usually genetically manifested, or sporadic. Can also be externally determined by lack of intake, vitamins or nutrients. And we distinguish that from acquired secondary Chiari malformations. If you tap too much fluid inferiorly, the whole brain sags down and you get the same effect at the craniocervical junction, but it's a different pathophysiology. So primary CNS Chiari malformation is much more common than secondary, and we focus on this for today. The epidemiology is a little interesting. The Chiari I is the most common type in adults, obviously, more often in women. I don't have a good explanation for this, but in my practice, the frequency distribution is 8 to 1, 8 females for 1 male. And it's more frequently recognized now in younger patients just because we scan more younger people. And it usually becomes clinically evident in adolescents and the 20s and 30s in most females. Chiari II is more prevalent in Caucasians and is the most frequent type immediately discovered in childhood. And the reason is that you have a spinal problem the patient is born with, and therefore it just manifests much earlier. I think the Caucasian prevalence may be a reporting problem, that we in the Western world have looked at this much more than others. It's a selection bias. Only the well-insured patient shows up in the ER for headaches. The one who has no insurance may never go diagnosed. So don't take this for granted. We sometimes do not study the right patient population. Prevalence estimates in the literature still says 1 in 1,000 live births likely has this condition. The reality is it's much more frequent. if you look at the radiographic data, it's 10 times that much. 1 in 100 patients that gets a report for whatever reason, fell down the stairs, got a CAT scan, the radiologist sends him to me and says, this patient has a Chiari and the patient never had any symptoms. So we need to figure that out in the future. There's likely underreporting, and many children with the condition may never ever show any symptoms, so you can't make a patient better who has no symptoms. As much as I love my job and I love this operation, I need to learn not to fix the image, I need to work on the patient. This is basically the summary. The initial study shows you a T1 image showing that herniation. The T2 image shows you that there's crowding. That's the key word you want to hear. You also want to check the bones. You often find affiliated bony malformations in these patients. So this is a classic patient that has a Chiari I with a cranial junction abnormality and atlas assimilation, but no myelopathy. There's no signal change in the spinal cord proper, no Syrinx, no hydrocephalus. So that's a simple case from a surgical perspective. What are these associated symptoms you can often find? There are bony abnormalities are listed for you guys. Atlas assimilation, accidental dislocation, clipal file anomaly means bones are fused that usually are not fused. Platypesia means the angle of the brain, how it's connecting to the brain stem is too flat. It's odd, shouldn't be there. There can be basal invagination that the spinal cord sort of migrates north, and there can be changes in the bone structure of the skull itself. So this is how it looks in CAT scans. Axial rotational instability means there is something wrong with the biomechanics at the craniocervical junction. These are the fused bones that are normally not fused. Clipal file shows you that there is fusion of vertebral bodies, changing the mechanical flexibility and structure of the cervical spine. This is platypesia, where you see there's a weird angle where the brain is relatively flat and then steeply changing to the junction. You can almost imagine there's a kink here right at the junction point. And Lückenschädel is the wrong term for this. It just means thinning out of the inner table of the bony cavity by increased intracranial pressure. It's not a typical Chiari problem. Sometimes you find intraparenchymal changes. That means the brain itself has structural abnormalities that we can pick up. Most typically, dysgenesis of the corpus callosum, left-right connections are thinned out. Agenesis of the septum pellucidum, the normal separation left and right of the brain, did not develop adequately. Polymicrogyria is the brain has some unfolding issues and the layering doesn't occur the way it is, so it's a developmental disease. And heterotopia means gray matter is scattered in the brain in places where it shouldn't be. So what's the best Chiari therapy if you have one of these patients in front of you? First, you need to define the disease. You need to identify it. And then you can say, what's your rule of thumb? My rule of thumb is this, very simple rule of 3. Asymptomatic patients can be managed expectantly. If you truly have no symptoms, don't fix the picture, right? Number 2, asymptomatic patients with a big syrinx sometimes request to be fixed because they are really afraid of this getting worse. And if you ask them carefully, I will tell you 90% of patients that say they have no symptoms have the symptoms. They have just accepted for all their life that something is off. They walk in cotton balls, they don't feel their hands so well, they have some sort of really weird little things they tell you about. They never like to paint over the ceiling because they don't want to extend their head, right? So those are the ones I'm willing to debate. And then symptomatic patients obviously need decompression because most of them you can make a lot better. For Chiari II and Chiari III, it's a bigger problem, needs bigger surgery. Most of them will need some fixation. Chiari I, let's just talk about one problem. Very simple now, second part of the talk. Wait and watch, we say, is not interesting for us today, but if you have no symptoms, do not be persuaded to get it fixed, okay? Surgeries, conceptually, you could do this from the front, from the back. You can just treat the symptoms. If you have hydrocephalus, just put a shunt in. It's simple, it's fast, it doesn't cost much, but it doesn't fix the underlying causality. And you can also fix the side effects of the syrinx. So we are talking about the junction. This is the view from the back onto the patient where the cerebellum meets the upper cervical spine. So my surgical recipe, and I apologize for the abbreviation, but it's the easiest to put it out there, is you can either do just a foramen magnum decompression and just take the bone out, number 1. You can do a foramen magnum decompression, take the bone out, and put a patch in to make the space bigger that is available for the fluid to get around the brainstem. Or you can do a foramen magnum decompression and take a piece of the brain out to create an extra piece of space space so that the fluid can get more easily in and out. And lots of my colleagues have done this for decades. The reason why we're willing to take out a little piece of the brain is that as of now, we have not identified what the tonsil, that little peg, is actually doing. So by taking it out, you cannot pick up a neurological deficit after its removal, which is a bit surprising because we have it for a reason, and that's the reason why I'm hesitant to take it out. Even if I don't know it, I may just don't know it, right? So we have 3 different surgical concepts. We can also do the same or similar stuff, minimal invasive surgery or endoscopic decompressions, and some people do mini craniotomies. Let's briefly talk about this. I will speed up a bit. Positioning, whatever the surgeon's choice, whichever your experience, what works in your hands is fine with me. Whoever heals is right. I really don't want to tell anybody how to do this. I do everything prone. Patient stays face down next to me. I stand to the patient. I'm a right-handed surgeon. I stand on the left side. I can do either a bony decompression only. I can do the duraplasty, putting in the patch to create more space, or I take something else out. Option 1. Bony decompression means you make a straight cut in the neck, standing behind the patient, you peel the muscles to the side, you see the bone, you literally just chisel out the bone. Fast, effective, safe, lots of surgeons like it, right? Well described in literature. That middle picture here is really beautiful, showing you, I have a better pointer, is showing you how this should look on a post-operative CT scan. So works quite well. How much bone do I take out? 2.2 centimeters, roughly the width of the spinal canal and the same height. That should give you enough space, but it really depends on the steepness of the P fossa. And then you cut the dural band, which is sort of a tight tissue connecting the posterior rim of the foramen magnum. Oh, there's a better pointer. Thank you. Yeah. Second option, this is, I think, what's interesting. You can do the laminectomy and the duroplasty. So same incision posteriorly, you drill out the bone, the red circle, then you make a Y-shaped incision in the dura, and you open it up, and what I usually compare it to is this game that kids play, fortune teller. Everybody knows how you fold this piece of paper. You fold the piece of paper, you open up the piece of paper, now you have a gap in your tissue, and you want to put a patch in. It's just like neurosurgical quilting, really. And it is exactly that. There's no mystery to this, right? And if you do this really well, I try to make this pretty, you peel these to the side, and then you put some form of patch in, and the patch is your choice based on the anatomy. This is how this looks in the surgery if the patient now is upside down. Some of my friends operate in the Concorde position. That means I stand at the head of the patient's body is away from me, so tail is there, head is here. You want to open up the junction of the neck to the P fossa. This is how this looks. Here you have opened up. This is the cerebellum, downwards. Here are the tonsils, and you just want to peel off that white arachnoidal web that tethers it down, and then you want to see that fluid is actually coming out of the fourth ventricle, can now reach the spine, and then you put in some form of patch to free up the CSF egress. Beautiful paper by a friend of mine, Lorenzo, from Switzerland. If you want to pull it, the literature is in there. Now, what are research questions for a surgeon? Just from a very practical perspective, right? How much bone do you actually need to take out? It's a really important question. It sounds ridiculous, but if you take too much, the whole brain will sag and you have the same problem from a bigger piece of tissue. And I've seen that. I've seen people who really try to do well, especially early in your career. You want to be capacious, and then you end up having a problem that you didn't have before. How much is too much, I said. And then is it enough to just untether the arachnoid, to take away these mini fibers that keep the tonsils wrapped to the surface of the brainstem? Or do you need to actually take out the tonsils? For the longest time, colleagues used bipolar cautery forceps, these electrical forceps. They buzz the tonsil shrinks, you have more space, but you took out one neural element that may need to be there at some point. And what's the best duroplasty material? So what do you use to put in the patch? You use the patient's own material, pericranium or fascia lata. Do you use some Gore-Tex, or do you use some xenograft, some other biological material? Makes a difference in how the body reacts to the repair of your surgical wound, right? And do you need to glue it, yes or no? And I'll tell you in a second why I think you do. Now, this is the literature, and this is the one thing you want to take home from this talk, I think. There's a beautiful meta-analysis. So it's called a systematic review meta-analysis. They pulled all papers available in the literature that had more than 15 patients, larger centers, good people reasonably standardized treatment, and they grouped the patients just like I did into bony decompression only and the outer layer of the dura. Group 2 is bony decompression plus a dural patch. Group 3 is bony decompression, take out a piece of the tonsil and patch it up somehow. And then they wanted to quantify how patients did afterwards. They pulled 1,242 patients, good cohort, and put it into different sizes. We only want to talk about the first 3 groups, relatively large numbers. Some got better, some got not better but not worse, and some got worse. Overall, 80% of patients benefit from Chiari surgery. Sounds pretty convincing, cool number, right? Most patients would say yes. But 14% did not get better at all, had surgery that was unnecessary, if you think about it. And 6% actually got worse. And that's a pretty big number these days. I'd say when I started training, patients would accept all sorts of side effects. Today they come in with a grapefruit tumor and they can't move their pinky and they sue you, right? It has really changed. So you need to pay attention to this stuff. So when you compare the 3 groups, the basic take-home message is patients with bony decompression alone fared clinically worse than those that had more done. So the bony decompression alone fixes part of the constriction, but does not allow for more space of the fluid to get around. So I have abandoned this particular approach. Less success, more reoperations, more headache, right? Because you had the operation, but you didn't benefit from it. And then there was no real statistical difference between doing the duraplasty and taking the tonsil out, yes or no, in terms of neurological recovery. But patients with large syrinx had a more profound reduction in the size of the cavity in the spinal cord if you did take the tonsil out. So there must be some flow dynamics that change when you decrease the size of the syrinx. What's really interesting is the second slide, the side effect profile. So when you look at what you do for surgery, all-cause morbidity and mortality is 20% of the patients, not the 80% that got better, 20% of patients had a problem after the surgery they didn't have before. That's not a small number, right? You really need to think about this. A new motor deficit, 6% of patients. Could be the difficult patients, could be the one with the big syrinx, could be the one where you try to dissect something and you violate a piece of the posterior brainstem, but it's a difficult thing. New sensory problems, 12%. Maybe you decompress too much, the brain sags, there's more stretch, patient has a new problem, right? But patients with bony decompression and tonsillar resection did by far worse than the ones that had the duroplasty done only. So my decision tree is based on equal efficacy but decreased morbidity. You do not take out the tonsil, but you do the patch, right? That's the line of thinking. This is what I do. It's basically midline incision. You do the operation, you harvest the patch of their own tissue, which I use pericranium just above my incision. Then you free up the brain in the back somehow. You quilt in that patch in a circular stitch. Then you glue in the patch, and then you close it all up. That works really well. We've published that more than 10 years ago. People really say this is technically a solid operation. I would encourage all of you to look at this. I think it's worthwhile doing. People want to know single steps, they can look at single steps. So this is how it looks post-op. You took out that piece of bone, white here, that was covering the cerebellum. You widen the spinal canal. You make the same opening in towards the P fossa. The cerebellum can then nicely expand. In the immediate post-op scan, everybody in my practice gets a scan within 4 hours. You can see the fluid gets around it. And post-operatively, you see there's a nice fluid patch now that can get from around the cerebellum posteriorly. And in white, it travels posteriorly towards the spinal cord. 2 alternatives. When I was in Canada, I was running McMaster University, one of my attendings tried to persuade me, you can do this easily, minimal invasive. You put it in a small matrix tube, which is basically like a little tube, looks like a channel, right? You put in the tube through the neck. You see here the tube in an X-ray from the side. You aim at the craniocervical junction, and you just drill out the bone. And he says, my patients are doing great. And I do believe him that many of his patients do great. Don't get me wrong. But I said, if you want to claim that is as good as somebody else, you need to have the numbers. You can't just say it works and it's much faster. And here comes a very honest statement to you guys. The billing code for this operation is the same than for my operation. He does it in 90 minutes. I need 3.5 hours to do a proper Chiari. I do understand that there's a fiscal element in decision-making in medicine that we have to take out. right? You need to disconnect the revenue stream from the patient's clinical decision tree. Otherwise, you will never get proper decision making. Other people have published that you can use the same matrix tube, see a little opening 2.2 by 2.5 centimeters, and you can still quilt in a patch. Conceptually great. I think it just makes your surgery more difficult, more likely to have trouble or leakages. For me, whether I make a 1-inch incision or a 1.5-inch incision makes zero difference for the patient. Most girls will never see the back of their neck under their hair, so it's not about aesthetics. It has to be practical and it has to be safe, right? So that's my decision tree for doing it this way. This is how they do it. This is just showing you the foramen magnum and the C1 arc. You can drill it out. This is the junction, and then you open up the outer layer of the dura, which I think was not good enough based on the meta-analysis. So my personal argument is put the patch in and then you do well. But yes, the advantages was it was fast, short length of stay. They go home on day 1. They have relatively little pain, and in 80% of patients it still works somehow, right? Well, finally, outcome summary. Improvement of symptoms is reported in roughly 80% of patients. Results differ based on the surgery performed. I think this is the way to go. Do the bony decompression plus the duraplasty. Bony decompression alone has a higher rate of reoperations. Nobody wants that. Nobody needs that. It's expensive and it takes you out of your day-to-day work, right? If you put in a dural patch, yes, you have a higher rate of CSF complications because you opened a space that wasn't opened in the other surgeries. But I can tell you this, I'm a tumor surgeon doing P-fossa surgery every single day of my life. My complication rate is 1%. And 1%, I think, for a big operation is an acceptable argument if you want to fix a problem there that has a lifelong impact. Most patients show decrease or near resolution of the syrinx, especially if you take the tonsils out. I have abandoned taking the tonsils out, but other people show me convincingly they have some patients that may still need it. Improvement and improvement of symptoms, especially headaches and neck pain, is the goal to go. If you can't fix the syrinx, you could go in for a different operation and just drain the syrinx. Very different operation in the spine. You split the spine proper, put in a mini plastic tube and connect it to somewhere outside, intradurally, extraaxially. Interesting operation. I've done it once in my life. I don't think there's a need for it, but I've heard from friends of mine, pediatric population, Shlomo Konstantini in Tel Aviv does this a lot. Good success, relatively low trouble rate, so I don't want to take this away from them. Thank you.